We have now come to the most important ingredient of the pinakbet, represented by the letter B, or the bagoong, without which you will not have the best tasting pinakbet from Northern Luzon. A blessed afternoon to all of you. I am tasked to talk about behaviors, so I decided to tackle commonly observed behaviors in children that parents struggle with, especially during this time of the pandemic. The angry, aggressive, and active child, ang batang galit at makulit. I aim to describe commonly observed behavioral problems, discuss causes and risk factors, identify management options, and emphasize our role as caregivers and pediatricians in their early identification and prevention of problem behaviors. I will specifically talk on temper tantrums, aggressive behaviors, and hyperactivity. So let's try to look into some clinical scenarios. Your clinic secretary comes to you and says, Doc, we have a patient, Zeus, 2 years, 10 months old boy. He is the youngest of 3 children, and the chief complaint is temper tantrums. You notice that he has an uncomplicated prenatal and birth history. He has normal motor milestones, but there is an observed lag in his language development. The parents say that at 1 year old, he can already say mama and papa. However, the progress was rather slow. During this time also, he was started on about 5 to 6 hours of screen time a day. When he was 1.5 years old, he would insist on what he wants by throwing a tantrum, manifested as crying, flailing, hitting his caregivers, throwing his toys. At present, you noted that he only has around 50 meaningful words, and he doesn't have any word combinations yet. He can, however, respond when you call him, and according to his parents, he can initiate social play. So you're trying to think, what kind of temper tantrum is this? And then your clinic secretary comes to you again. Doc, there's another patient waiting outside. Zion, nagwawala na po siya sa labas. She said, Zion is a 3 years, 5 months old boy and is the eldest of 2. His sibling is 1 year old. And the chief complaint is also temper tantrums. He also has an uncomplicated pregnancy and birth history. This boy, however, has a normal motor and language development. He also was started on about 5 to 6 hours of screen time a day at 1 year old. At 2 years old, he can already identify the alphabet, he can identify colors, numbers, and shapes. However, when he is frustrated, he hits his head on the floor. He throws his toys and turns table and chairs over. At 3 years old, the parents were very surprised because he can already read well. However, he prefers to play by himself. He does not engage his caregivers when asking for what he needs. And when he was frustrated, he started hitting himself by hitting his head, hitting his face, and hitting his chest. Then you think, what kind of temper tantrum is this again? Which brings me to the discussion on temper tantrums. Temper tantrums are brief episodes of extreme, unpleasant, and sometimes aggressive behavior in response to frustration or anger. And we know that this is typical in toddlers. It is common between the age of 2 to 3 years old. They can manifest as crying, screaming, going limp, flailing, or throwing away their arms and their legs, or parang naglulupasay na sila, or even hitting. They can throw items within their reach. Some parents also observe breath-holding spells or pushing or biting behaviors. Typically, it usually occurs once a day with a median duration of 3 minutes in 16 to 18 months, 18 to 60 months old children. We know that in toddlers, they have this desire for parental attention. However, they also have this desire to be independent. They have this strong will to be independent. So this struggle then brings them to throw temper tantrums. More often than not, these are triggered by physiological factors like fatigue, hunger, illness, or frustration. So the mom comes to you, Doc, hindi pa kasi na kumakain, nagugutom na. Doc, inaantok kasi, kaya nagwawala na. So these are physiologic triggers. And these toddlers use tantrums because they feel these are effective ways to get what they want. Or this is a way for them to avoid what they do not want to do. And they also throw tantrums when they are prevented from exploring their environment. As a child, however, learns to identify his feelings, learns to name his emotions, and communicate his feelings to others, the frequency of temper tantrums should decrease. Now, there is such a thing as normal tantrums and abnormal tantrums, or typical and atypical tantrums. So let's differentiate the two. Normal temper tantrums are seen in children aged 12 months up to 4, and they will manifest as crying, flailing of the arms or the legs, falling to the floor, pushing, pulling, or even biting. Or sa atin, sometimes we even see them spitting. Now, if they continue on past the age of 4, and they already cause injury to themselves and to others during the tantrum, then it is already somewhat an abnormal temper tantrum. In normal temper tantrums, it can last only up until 15 minutes. And if it lasts longer, you should look into some problems. Typically, it can occur in less than 5 times a day, but if it happens more than 5 times a day, then it's already a cause for concern. Children with normal tantrums usually return to normal moods between tantrums. However, there is persistent negative mood between tantrums in children with atypical temper tantrums. What are atypical temper tantrums? Okay, let's describe. These are repeated patterns seen in children more than 5 years old. It lasts more than 15 minutes. It occurs regularly more than 5 times a day, and they can manifest with extreme aggression. It can even result to physical injury or destruction of property. Some children will also manifest with some behavioral problems like sleep disorders, enuresis, or they cannot control their bladder when they should, and they have persistent negative mood behaviors. And what are some of the conditions that when we see atypical temper tantrums? We see this in children with disruptive, impulse control, and conduct disorders, such as those with oppositional defiant disorder. We also see them in children with post-traumatic stress disorder, or those with major depressive disorders. We also observe them in children having developmental and neurobehavioral disorders, such as attention deficit hyperactivity disorder, autism, learning disability, and those with central problems like vision or hearing deficits. Now, there is an increasing evidence that children with language delay are have more frequent and severe temper tantrums, just like our patient Zeus. Okay, so we noted that he has late language development. And in this case, late talkers are defined as toddlers on the average around 2 years old with less than 50-word vocabulary and with no 2-word phrases. And severe tantrums occur twice likely in late talkers. And they notice that there's a link between language delays and mental health risks. That is why we would like to also emphasize the importance of monitoring the language skills of our children, because this will greatly affect their behaviors. What about Zion? Because of limited skills to express himself, we see temper tantrums in children diagnosed with autism. However, They are usually called meltdowns instead of temper tantrums. And they're not only limited to children with autism, they can also manifest in adolescents and even in adults with autism. They're preceded by signs of distress, which they call rumblings. When you see it when a child suddenly is overwhelmed, and then he starts pacing the room. He starts mumbling words like "go home, go home, go home," or he starts covering his ears. It means he's too stressed, and then it's the beginning of a meltdown. And it may involve intense stimulatory behaviors like rocking, pacing back and forth, or finger flicking. These meltdowns do not have a purpose, but are genuine signs of distress. So it is important also to identify these children so that we would know how to target these behaviors. Now, what do we advise our parents if a child is throwing a tantrum? Of course, top of the list, we ask them to remain calm. More often than not, if a child goes into a tantrum, the parent also goes into a tantrum. So he scolds and yells at the child, and then the tantrum escalates. So we ask the parents to remain calm, okay? If they both need a quiet time or to have a timeout corner, then do so. And then we advise the parents on the negative reinforcement, or we ignore the tantrum. So if a tantrum usually calls for an audience, ibig sabihin, kung ang bata pinapanood mo nagtatantrum, lalo siyang magtatantrum. So we ask the parent to ignore the tantrum. And in younger kids, it's usually effective to distract the child. Also, we advise them not to give in to a child's demands, except when meeting their child's physical and safety needs. If the child is already put in hazard, then we can address that immediately. We have to wait for a tantrum to subside, and then we ask the parent to offer nurturance to the child. We will try to speak to them and talk to them calmly. And in the process, we help a child express negative feelings in more acceptable ways. We teach them to express their emotions. We teach them to say if they're sad, they're angry, they're happy, or they're scared of what's happening. So we ask them to express their feelings so we can process it together. And then we always emphasize developing a structure in the home setting. When we say structure, there is a schedule of tasks that the children will have to follow throughout the day, so that they know what activities are allowed, what activities are not, what is the next activity to be completed. So it's like a schedule of rules as well that children will follow, so that there's no reason for them to misbehave. Okay, and then most definitely, no to physical punishment. This is because if we use corporal punishment or physical punishment to address a child's tantrum, he will feel that it is okay for a parent that when he is frustrated to hit a child. So the next time around, if the child feels frustrated, he might also learn to hit the parent. So we do not use physical punishment to address a tantrum. Okay, so by this time, we should be able to identify what kind of tantrum our patients are already are showing, so that we know what kind of advice to give them. So let's look into our third clinical scenario. After lunch, your clinic secretary calls you. Doctor, we have another patient. Mas malaking bata, si Zian. 8 years old male. He's an only child. The chief complaint is aggressive behavior. History shows that he was adopted at birth, so his prenatal, his birth, and family histories are not known, except that the parents were told that he is a product of a multigravid mother. Both his adoptive parents are working as virtual assistants, and during this pandemic, worked from home. So he has normal developmental milestones, and he is an achiever in preschool because the parents dedicated their time to really monitor his progress as he was growing old. When he was in grade 1, he was exposed to gadgets. He was given his own iPad. However, with excessive use noted during the quarantine period because the parents were already working at home, so they had no more time. So, tatlo na silang naka-gadget. And then, when he was enrolled, they noticed that he had lost interest in his online classes. He would rather use his gadget. He would stay up all night, and in the morning, he's so lazy to attend his online classes already. And then they noticed already disruptive behaviors. He was destructive to property. He kicks the door. He bangs the surfaces of their table when he's angry. He already started aggression towards his parents. When asked to stop using his phone, he hits his parents and he showed extreme agitation. So we see this behavior common, especially during this time of the pandemic, when children are not given limits and are in control of their use of social media or digital media. So let's go to discuss violent behaviors in children or aggressive behaviors in children. Any violent behavior at any age in a child should always be taken seriously. This can be manifested as explosive temper tantrums or physical aggression, fighting other children, or threats or attempts to hurt others. Some of them would actually even use weapons or even manifest with cruelty towards animals. In older children, they can have fire-setting behaviors and they have intentional destruction of property or even vandalism. So what could be causes of aggression in children? So there must be something that pushes children to be aggressive or to be violent. They may be suffering from mood disorders like depression or anxiety or fears. They may have an underlying mental health problem or psychosis. Or they may be frustrated because of impairments in cognition, such as those with intellectual disability. Or they may have impairments in communication, such as what we discussed earlier, children with autism. Or aggression can be a manifestation of impulsivity in children with ADHD because they cannot control themselves and without even really meaning to hurt, they tend to do it because of their impulsivity. Children also with conduct disorders or those with history of injury or trauma, especially to the central nervous system. Now, what triggers these behaviors? So these are factors that increase the risk of violent behaviors. A child who has a previous aggressive or violent behavior is at a higher risk of, again, showing these manifestations. Or children who are victims of physical or sexual abuse, exposed to violence in the home or in the community, children who are victims of bullying, and also genetic factors. The father could have manifested these behaviors also when he was young, or cousins have these problems as well. No? And then we will see here exposure to violence in media, or in older kids, in adolescents, possibly they're using drugs or alcohol. No? And then we also look into stressful family socioeconomic factors. We look also at possibly triggered by brain damage from head injury. And in some homes, the presence of firearms pushes the button in children to become also aggressive, no? Because they see na, I can use this and I can use this to harm other people because why is this here? Parang ganon. Okay? So how do we prevent violent behavior? Knowing all the risk factors, we will really try to decrease the exposure of children and adolescents to violence in the home, in the community, and through the media. So if we ask our parents, what do you do? Where do you live? What's going on in the home? Is there any form of domestic violence? May mga nag-aaway ba sa kapitbahay? Huh? So we will look into that so that we can know how to control it. No? And of course, prevention of child abuse. We also have to educate our teens on sex education and advise parents on programs that are ideal for adolescents. And most importantly, we monitor child's screen time. And our goals of treatment should be to help the child to learn or to learn to control his or her anger. Okay, we will help the child express his anger or frustrations in appropriate ways. Yung hindi na lang basta-basta nagwawala, but try to let him speak it out. No? And then we will help the child to be responsible for his or her actions by accepting consequences of his behaviors. So these are consequences and not punishment. No? And if you looked into some of the risk factors, then you can address family conflicts, any school problems, and community issues as well. Now, there is an increasing evidence of on-screen violence and the presence of real-world aggression among our children. Some studies say there is no correlation. However, there is now an increasing evidence, and there are more studies to show that really children are affected by what they view on screen. What children watch and play changes how they behave. And we see a lot of the games now with violent themes. So if children are using these games or playing these games, they become immune or numb to the horror of violence. They would accept violence as a way to solve problems. Remember, these games are, you are rewarded for the violent behaviors that you show. You are rewarded when you kill a person. You are rewarded when um, you do something bad. So your score gets higher. So children will tend to imitate violence that they observe from media, especially if they're playing it for long periods of time. Some of them identify with some of the characters, or some of the characters, the victims or the victimizers. So this is really a very unhealthy use of media. So what do we suggest? Okay, so as caregivers, we recommend the judicious use of media. If at all possible, we ask them to use the traditional books. No? Expose our children to books, to reading. Okay, and when necessary, we try to also be models of sharing media content where good can come out of bad news. Now, in the middle of all of these bad news, we can share media content where health workers are helping those who are sick, or the vendor sharing his goods in the community market. So these are good content, so that it can cover the bad news around. In younger kids, not only in younger kids, even in older kids and teenagers, we recommend co-viewing. And what is co-viewing? We ask the parents to sit down beside the children and watch whatever programs they're watching. No? So in younger kids, we ask them to tell what's going on, what's Barney doing, what shape was that, what shape was being asked. No? So we have an interactive form of learning. In older kids, we can probably play with them their games so that we know what kind of games they're playing with, no? Or we become friends with them on their Instagram account so that we know what kind of views they're viewing, or what kind of posts they are putting online. We choose child-friendly shows. Sabi namin, developmentally appropriate shows. Gone were the days when Sesame Street was aired every week, or our local form of batibot. Wala na ngayon. And that's just for 1 hour. But now, there's 24 hours, 7 days a week programs on screen that a child can get hooked to. No? So we ask the family to make a family media plan. So we will tell them to list down the why, the what, why do you use it, where, and where, what do you use, gadget or TV, where, in the family living room only, not in the bedroom, or when. only an hour after your school, only an hour for game time in the afternoon, and to surrender your gadget 1 hour before sleeping time. Okay, so these are the things that we can advise our parents. Let me talk briefly on this disorder, this disruptive mood dysregulation disorder, wherein children show extreme irritability, anger, and frequent intense temper tantrums or temper outbursts. It goes beyond being moody, and children experience severe impairments. Symptoms typically begin before the age of 10, but the diagnosis is not given to children below 6 or adolescents above 18. They're irritable or angry most of the day, nearly every day. They have severe temper outbursts, usually verbal or sometimes behavioral, at an average of 3 or more times per week that are out of keeping with the situation and the child's developmental level. Because of that, they have trouble functioning due to the irritability in more than one place, not only in the home, but also in the school and even with their peers. It is important to note that these outbursts and tantrums have been ongoing for 12 or more months. So this is a relatively new disorder which came out with the DSM-5 in 2013. So studies are still ongoing as to what's the spectrum of this disability. However, medications are already being used to control these problems, and the usual psychosocial interventions or therapies. So let's look into our last clinical scenario. So Zoe, uuwi ka na, but your clinic secretary said, Doc, may pahabol, isa pa, si Zoe. Zoe is a 6-year-old male. He's the older of 2 boys again. His younger sibling is 2 years old. The chief complaint this time is hyperactivity. In the history shows that pregnancy was complicated by threatened miscarriage in the first trimester and threatened preterm labor. So the mother was mostly confined to bed during the pregnancy. He, however, was carried to term and he had an uncomplicated birth history. He was also treated for bronchial asthma, mild, intermittent, when he was younger. There was a mild language delay at 2 years old, which resolved through speech therapy for 4 months. He was described to be very energetic. At 2 years old, he runs instead of walk. He climbs on anything, and he enjoyed the outdoors. At 3 years old, he was enrolled in daycare. And the teacher described him to be playful, inattentive, and disruptive in class, which are usual behaviors at 3 years old. At 4 years old, he was again enrolled in a regular nursery class of 20 students. He was hyperactive, he was playful, he keeps on moving around the classroom, and he disrupts other children. At 5 years old, during the lockdown period, he was enrolled in kindergarten through a synchronous mode of learning. He refused to write. He easily forgets the lessons learned. He has no patience with completing his modules. Currently, he has difficulties remembering the alphabet. He's already enrolled in grade 1. However, he gets confused with colors. He has learned to write his name. However, every time he does, there's always a wrong spelling noted. However, he is noted to navigate the digital platform very well. So he's very good at using gadgets. Now, what will we consider if this child comes to us? Let's look at possible causes of hyperactivity in children. Top of the list, can this child have ADHD? Or are there other medical symptoms that can point to hyperthyroidism? Is the neurological examination consistent with a brain disorder or nervous system disorder? Is there a presence of a psychological disorder? Could he be under so much stress? Could he be also be showing signs of depression or anxiety? Or let's look into environmental issues. Is the family consistent? Are the rules in the home followed? No? Is there exposure to family dysfunction? Okay, so let's talk about what's on top of the list, ADHD. We discussed this already in previous webinars, but I'll just run through it briefly. It is the most common neurobehavioral condition in children. It is diagnosed in childhood and even often lasts into adulthood. Prevalence study says on the average, there are 7.2% of children affected and 2.5% of adults, and it is most common in boys. Children with ADHD manifest with inattention, hyperactivity, and impulsivity. And the behaviors are developmentally inappropriate. It can cause significant functional impairment such that they have academic underachievement, they have problems with interpersonal relationships with family and peers, and children with ADHD have low self-esteem. What are the causes? Interactions between genes and environment, the so-called epigenetic mechanism, or even pregnancy complications like exposure to smoking, to alcohol, to drug, exposure to environmental toxins, birth problems like low birth weight or brain injuries. No? It is not due to eating too much sugar. It is not due to food additives, allergies, or it is not due to immunizations. So comorbidities are more the rule than the exception, meaning children with ADHD will have comorbidities more than not. Huh? And most of them will manifest with language and learning difficulties. And externalizing conditions are actually more prominent in boys. These are the oppositional defiant disorders and conduct disorders, while internalizing conditions are predominantly observed in girls, such as anxiety and depression. So we know about ADHD, but something we do not know is about learning disability. So I'll discuss that in a while. Now, how do we manage ADHD? Psychotherapy, pharmacotherapy, psychosocial interventions, school-based interventions, and of course, support groups. Now, let me bring you to a discussion on learning disorders because children with hyperactivity can actually have learning disorders. They have difficulties learning and using academic skills. It persists over the last 6 months, and the affected academic skills are substantially and quantifiably below those expected for the individual's chronological age. It can interfere with academic or occupational functioning or with activities of daily living. What are the manifestations? Children with learning disorders can either have specific impairments in reading, manifested as slow, inaccurate, or ineffortful reading, difficulties understanding what has been read, or they can have specific impairments in writing, manifested as difficulty in spelling or difficulty in written expression. They can have specific impairments in math. They can show difficulties in mastering number sense, number facts, calculations, and math reasoning. What are the causes? Similar to ADHD, genetics play a role. There is noted insults to developing brain before or during birth, such as maternal infections or injuries, drug or alcohol use during pregnancy, maternal malnutrition, low birth weight, oxygen deprivation, premature or even prolonged labor. Postnatal, we see traumatic injuries that can cause learning disorders or even severe nutritional deprivation. Even exposure to poisonous substances such as lead. So we see there's really a brain dysfunction or a functional impairment in the brain of children with learning disability. So what are common signs or that we see in the clinic? So you ask the child, and he has difficulties telling right from left. You ask him to write, and you see letter reversals, word or number reversals, noticed when after the first or the second grade. He has difficulties recognizing patterns or sorting items by size or by shape. He has difficulty understanding and following instructions or staying organized. He can't remember what was just said or what was just read. He is a little bit clumsy. He has difficulties doing tasks with his hands like writing, cutting, or drawing. And he also has difficulties understanding the concept of time. These are examples of a written work of children with significant learning problems. So you see the misspelling, the letter reversals, and the number reversals. B instead of D, no? 2 instead of 5, So how do we manage learning disability? Similar to ADHD, we do academic interventions. So we recommend accommodations in the classroom. We recommend curriculum modification, remedial lessons, or classroom interventions. So the child can be seated beside a classmate who is a good reader, or in front of the room in front of the teacher, so that the teacher can monitor him. We also do psychological interventions to educate the family and refer them for support therapy. We also treat comorbidities. So this way, we treat ADHD, we treat depression, we treat the anxiety, or we treat whatever comorbidity is there. Unfortunately, we don't have any pharmacotherapy yet for learning disability. So what about COVID-19? What are the effects on children's behavior? We see increasing evidence of difficult behaviors in children because of this pandemic. We see children manifesting with inattention, irritability, worry, and increasing fears. So this study is a compilation of several studies showing that children have an increase in externalizing tendency. They're more irritable, they are intolerant to rules, they have excessive demands. They manifest with excessive nervousness, worry, feeling of loneliness, boredom, and anger. There's impaired quality of sleep and sleep stabilization. We know that sleep is very important to have good behaviors. So there's also a manifestation of greater psychological distress like worry, helplessness, and fear. And in adolescents, we see an increasing evidence of depression. So what is our role? We talk about surveillance, and we always emphasize this to our caregivers, to our pediatricians. Surveillance is an ongoing monitoring of a child's overall well-being at critical periods and during well-child visits. So we recommend that every time a child comes to you, to see his overall well-being. You monitor his growth, you monitor the development, and you monitor behaviors as well. How can we prevent? Because of your proper history, proper psychosocial history, you will be able to identify the risk factors that can promote behavior problems. And you can educate your parents about this. Or you can also identify protective factors and help promote it. And what about early intervention? Because you're able to identify the problem earlier, and you're identified to see the capacity of the caregivers to promote problem behaviors or to protect children from it, then you can give specific advice to your parents and to the families. Of course, you will help promote positive caregiver-child interaction patterns. And when necessary, you can always refer to your friendly specialists. We are here. We can also refer them to our child and adolescent psychiatrists or to our psychologists. So what is a summary now of our assessment? So we see Zeus, a toddler with language delay who has difficulties expressing himself. He can't say if he's hungry or if he's wet or if he's sleepy. We also have Zion, a preschooler who has difficulties with managing his emotions due to social and communication deficits, and who may be overwhelmed with a lot of sensory inputs from his environment due to autism or intellectual disability. And we have Zian, a school-aged child with not a very ideal environment, exposed to domestic or community violence, probably, and exposed with uncontrolled exposure to violent media, and with lack of parental involvement, who longs for attention. And then there is Zoe, our primary school-aged child, who, due to genetic factors, has an uncontrollable high levels of activity and energy, and who is so frustrated because he could not catch up with his academics. His letters and numbers seem to be flying around the paper. Yes, ADHD and specific learning disorders. So there are significant and several reasons why children nowadays manifest with behavioral problems, plus the stress of the pandemic. So we are the only we may be the significant person who can help them, who can help the family address these behaviors. And I like this quote from our speaker during our last convention. He said, "Love is seeing someone as they deserve to be seen, as they really are, not through the lens of the behaviors they have sometimes needed to display, nor the labels they may have received." So it is important for us to really support these children, to find out the help that they need, and to support our families as well. Thank you for your kind attention and have a blessed day.